Everyone. Good evening. I am Cora Peck. I'm one of the admins in the Pudendal Neuralgia Hope Facebook group. Today I have with me pelvic floor therapist, Dr. Tracy Sher. She is the owner of the private practice Sher Pelvic Health and Healing located in Orlando. And she is the founder and CEO of the global platform Pelvic Guru Pelvic Global and the Global Pelvic Health Alliance membership. She has specialized training in pelvic physical therapy, strength and conditioning, and sexual health. And Tracy has a passion for treating complex pelvic health cases relating to pelvic pain, sexual pain, pudendal neuralgia, and postpartum changes. She has been a wonderful member of our Facebook group for many years, and she has graciously taken the time to answer some of your submitted questions. So thank you very much and welcome, Dr. Tracy Sher.
All right. Thank you so much. I believe we are just switching out. I don't think you can see my screen yet because Cora still has the speaking light, but I just want to say hi and introduce myself. What I'm going to do is I'm going to switch to my presentation, and I'm not sure I don't know if you'll be able to see me there either, but I am here, and let's see if I can do that.
I might be able to, hold on. Oh, I see. Yeah, I see. Well, I saw for a brief moment.
Yeah, the presentation, I just have to pull it back up. For some reason, it did not stay up. Let me see here. Okay, hold please. We will get this going. It went to a different screen is what happened. And
Okay. No worries, no rush. We're good.
We are so happy. We were actually so excited that we were able to get into the Facebook group. That was the first big exciting thing, right?
First big hurdle.
Yeah, exactly. And then now we are going to, okay, I think I got us. I got us back where we need to be. Okay, so we are going to share. There we go. Okay, so now I have got us back to the presentation.
Excellent. Yep, I see it. Perfect.
And I don't know, Cora, if you can change it, but it still shows you in the box and not me teaching, which is fine, but I didn't know if you're able to switch the speaker.
Well, maybe I can. Actually, it says you're pinned for some reason.
Okay.
Hold on. I don't know.
And that's fine. I don't mind if we have you smiling.
Oh, I do. I don't want to be on there. Hold on just a second. What if I do this? No. Give me 1 second. How about that? I keep forgetting it's slightly delayed. Give me 1 sec.
If you turn off your video, I don't know if it switches, but that
yeah, that's a good idea.
Or it might just stay without anyone there. I'm not sure. Yeah.
Okay, hold on. I have one more idea. What if we make you host? See if that helps.
There I am. Yes, there I am.
Okay. Excellent.
So hello, everyone. I am happy to be here, and I will get started on the presentation now. What we're doing today is I'm doing a presentation to help basically bust some myths and really try to provide hope for you. My mission has been for so many years to tell patients that there's a lot of hope. And sometimes when you're dealing with this, it can feel hopeless. And I don't mean just kind of to stuff everything and be like, everything's wonderful. But I think that a lot of times with the right guidance and the right clinical reasoning, there are a lot of ways to get help for this. And so that's why I try to jump into this group as much as I can to help when I can, because I feel like there are so many things to consider. And when you're having your own pain with this, you can feel like very confused, and it can feel hard to take on by yourself. And so that's why I'm here, to give you a lot of hope and to try to really help you navigate this as best as we can. So one of the things I'm using a lot of the slides that I do when I teach courses, and I teach all around the world. I teach all about pudendal neuralgia. One of the big things is I feel like we're drowning in information, but starving for wisdom. And why I say that is There's so much information now. You can type in Pudendal and get tons of things online. I mean, as you can see, there's all sorts of information out there. There's information on videos, there's information in AI all over the place. But the question is, how much of it is actually wisdom that relates to you as opposed to just lots and lots of information, right? So I call it, when we started teaching this course years and years ago, I've been teaching my one Pudendal course for about 15 years now. And Loretta Robertson and I coined the term the Pudendal Tour because we regularly saw patients who were coming in from all over the world and they tended to do a similar path. They would first potentially go to Dr. Potter in New York for imaging. Then they might go out to California for imaging because they wanted to get an MRN. Then they would go potentially for blocks at different places. They would stop with Dr. Conway, with Dr. Hibner. They might go to Osman in another country. So we started seeing this. Then they'd go to pelvic rehab at specific locations. So by the time I would see a patient, they could have gone to 10 different places trying to find help for this. So it became this Pudendal tour. And what I've been trying to do, I've been on a mission to talk to and teach physicians and pelvic therapists all around the country and the world how to get better at helping patients locally so patients don't have to travel all over the world to get help. And so one of the things I'm really excited about talking to you is that I can also impart this information for you so that you feel more empowered to ask the right questions and to get the right help as well. So that is a big goal for me. I took this was years and years ago when people were on the Pudendal Neuralgia Hope groups. I saw lots of comments and I picked a few that really resonated with me because this is what I see with my patients. Someone said, we searched for years for answers, finally got some, and the diagnosis was devastating. I am plunging into depression because I was diagnosed with pudendal neuralgia. Now that I know the diagnosis, I know it is hopeless based on what I have read. And that's exactly why I'm so excited to have this opportunity, because to me, when someone comes to me and says they have pudendal neuralgia, I'm like, okay, cool. Now we can get started on figuring out what to do to help you. That's just a label. And there's so much we can do to help you. Okay. And I didn't mean, okay, cool, as in it's cool that you have it. More just like this just gives me an idea of what could be going on. But now there's a lot more that we can figure out what's happening. Okay. So when someone says this to me, I feel so sad that they've been reading online and getting information that it's hopeless, because there's still a lot of hope for you, okay? Another person said, I just wanted to say I've had my 2-year anniversary yesterday of pelvic floor therapy twice a week. Well, it's cost us somewhere around $20,000 cash so far, and I'm getting some changes, but it is very slow. But I've had my PNE pain for many years, so it's going to take some time. And the reason why I chose this is because I also feel so sad for patients that are spending tons of money on this, that it feels like they're going from place to place and having to spend a lot of money. And I often see things that can just be bypassed, where you can do something that's going to cost a lot less, or there's ways to do it where you are making sure that you don't necessarily have to do all the steps. I tell people, if you're going to the same person for the same treatment, it's been 2 years and you're not getting any better, that's not in the right direction. I usually know within 4 to 6 visits if I'm on the right track or if we need to change some things with my patients. I would not keep someone for 2 years if they're not making any progress whatsoever. It should be pretty quick in the first few months that we're going to know. And then often what I like to do is make sure I'm tag teaming with other people that I think would be a good adjunct for care with them, or the primary care person. So there are decisions that should be made relatively quickly instead of staying with someone for lots of years, hoping that it'll finally get better with them. There are many people that specialize in this now, and it's finding the right help for you. Unfortunately, where it can sometimes get expensive is I know sometimes patients have to travel to go get the right care. And that's why I'm on this desperate mission to make sure more people are trained and have more information about this so that you don't have to travel as far. But it's definitely something that I know not everyone has access to the care that they need. And it really is tough and frustrating and sad for me to see this. So just a little bit about me. I've been a pelvic physical therapist for 25 years. I can't believe it's been that long. And I've been dedicated to really complex cases for many years now. I do have a strength and conditioning background as well. I've been doing personal training since that time as well. And I also have been trained in sexual counseling. So I put that together to essentially tackle all the different components, whether it's strength and conditioning, whether it's sexual health, and all of the pelvic physical therapy and orthopedic physical therapy components. At this point in my career, I do a lot of case management. So I'm trying to help manage cases on a different level than just doing hands-on. I'm really trying to figure out where do they need to go, what's really going on, what's at the heart of these patients' problems. That's really been my focus. And so I'm in Orlando, Florida. My actual practice is because I'm teaching so much and I'm involved in a lot of education, I'm not there as much. So I do still do telehealth and I do see some cases, but it's harder to get in to see me, unfortunately. But I am available if you have questions or to do telehealth at times. There might just be a little bit of a wait. And I also work with many people that I can refer as well. That's the goal, is to make sure that you're getting the right help for what you need. I've taught for Herman and Wallace. I teach for the Pelvic Global Academy, which is my academy. And financial disclosure, I do have a practice in Orlando, and I do have the Pelvic Global Academy. So I want to be clear about that. Okay, so I do also have a course, and I've been teaching this course now alongside, it was Loretta Robertson and I that started teaching the course about 14, 15 years ago. And we joined forces with Dr. Castellanos and Dr. Hibner for a while, and we were doing some teaching things with them. And I've had a chance to go all over the world. I've been to Israel and Turkey and France, UK. Where was I recently? I've been all over. So I go all over and teach. And it's been very satisfying to know that there are more people in the world that are trained in Pudendal. It's definitely needed. And you can see that I've teamed up with many different physicians along the way and learned a lot from them as well. And I want to tell you that all of the people here, so there's lots of people that you might recognize from Hibner, Castellanos, Boutrant, Erwin Goldstein, and Andrew Goldstein, and Dr. Conway, Dr. Hibner. What you'll notice is we all have our strengths, and we all have different specialties. So within pudendal neuralgia and pelvic pain, we are all essentially tackling this in different ways. And so I would just say that there are blind spots that many of us have, but many of us have strengths as well. So if you're finding that you're working with someone and they're getting you some help, but you still need more help, understand that there might still be ways to navigate that to get more help, whether it's just a telehealth that you can get more information, or whether it's a different kind of imaging. There's lots of different ways to continue to get help. Okay, they're all really brilliant. And we all also sometimes, have to sit back and say, wait, where are my limitations? How can I help, or where am I missing? Okay. So a larger thing that I wanted to share with you is that within pelvic pain, and even under the umbrella of pelvic pain with pudendal neuralgia, any of these things can be going on. There can be anything from biomedical to additional things with nutrition, sleep, stress, all the life factors as well. So a lot of people say, well, I have pudendal neuralgia. What do I do now? And the question is it purely pain in the distribution of the nerve, or are we dealing with a dermatologic issue? Are we dealing with a hormonal issue? Are we dealing with peripheral nerve issue itself? Are we dealing with the central or spine neurologic issue, orthopedic, other kinds of pelvic floor or MSK, musculoskeletal issues? Is there a vascular component? Is there any other kind of medical condition? So for example, some people have such significant bowel impactions or bowel problems that is what's causing a lot of their pudendal nerve pressure. There are people who have tumors in the area. I've caught a few patients that have had tumors that we caught. I've seen patients with hernias. So while they're being diagnosed with pudendal neuralgia, there's actually a medical diagnosis underneath that we need to keep looking and digging for that information. Oftentimes what I find, it's multifactorial, and this is why we need what we call multimodal care, where you'll have someone that has an orthopedic condition. They might have a hip problem, but actually they also have pelvic floor tightness, but also they might have a hormonal component where we just get some good vaginal estrogen. And they do really well when you treat all three of those things. But if you only address one of those things, they might not see the full effects. And so a lot of people in the group would say things like, I've just never seen anyone get better. And I'm here to tell you, there's so many patients that when we get them the right combination of things, many of my patients are much better. They're either managing it really well, or they are completely better once they're on the right track. For example, there's patients that are dealing with problems where it's been an estrogenic issue, where they do need vaginal estrogen, for example, and applied in the right area at the vulva. And with the right treatment, within 3 months, their symptoms might have gone completely away, where they didn't even know that that was an option, because they didn't know that you could do vaginal estrogen for that specific issue, that it was never looked at in that lens. They were seeing urologists or neurologists who weren't thinking about the hormonal component. So sometimes it's just a matter of tweaking it and figuring out, is there something we're missing in this case? So that's a big piece of it as well. Okay. So I put this is something I do when I teach. I just want to go over a few cases. So the reason why I bring this up is to share with you that even though someone's saying they have pudendal neuralgia, there could be 5 different things, 10 different things going on that are different for each person. So when someone goes in the group and says, hey, I have this problem, what do you think? What have you done for it? But the problem is we don't know what the underlying issue is, why this person is having their symptoms. Okay. So I'm going to show one example. There's a person with testicular pain. They have sudden onset, unremitting for 2 years. Okay. This is a patient I had. They thought he had some sort of neuralgia in either spermatic cord or testicle. He had injections. That didn't work. So then they did denervation of their spermatic cord. And when that didn't work, they offered him another selection, which was, well, we can do an orchiectomy, which is we can remove the testicle. And that was basically his treatment path. There was no other looking at other components of this. That's what he was offered. And he said, well, I had injections, that didn't work. I had denervation at that spermatic cord, that didn't work. So I guess I might as well try having my testicle removed. And he said he woke up after the surgery and he was so upset because the same pain that he had prior, he had the same exact pain. It did not go away. Okay, so he did have some lumbar screening and it was negative. So, okay, so we knew there wasn't anything major in the lumbar area that they could see. And then I'm going to show you another case, and we're going to go through all these. This is a patient who had penis pain, and he kept coming in saying he can't sit, but it's actually soft surfaces were terrible, and it was tolerable on hard surfaces. So he would sit on a harder seat, he was okay, but soft surfaces were not. I'm sorry, soft surfaces were an issue. And he was treated for 13 years for pudendal neuralgia and pudendal nerve entrapment for 13 years. He had numerous pudendal, posterior femoral cutaneous injections, cryoablation, pulsed radiofrequency. He had pudendal nerve decompression surgery, and nothing changed his symptoms. Okay, so he came to see me from out of state, and I try to look at it from a different lens. Okay, and I want to show you, once we go through these cases, you're going to see I looked at this from a different lens, and he ended up being about 95% better. So keep that in mind. This is a case where he had even had nerve decompression surgery and it didn't help him at all. And another case is a patient who came to see me from another state, and she was dealing with deep stabbing vaginal pain and clitoral burning. She was supposed to be scheduled for a bilateral pudendal decompression surgery with piriformis resection. And because she said that the MR, I believe she had an MRN, showed that she had bilateral pudendal nerve entrapment via piriformis compression. Okay. So let's go to some of these answers here. I think this is really important for you to see what happens. So with this particular patient, again, every patient is going to be a little bit different, but this particular patient with sudden onset, unremitting 2 years. Basically, when I went and palpated, I did some manual techniques at the S2, S3 area of his spine on the left side. It reproduced all of his symptoms. And so I worked on, even though his lumbar imaging looked okay, he was having some sort of significant nerve irritation at the spine still at S2 and S3. So we worked on positioning. I had him in some strange positions up with some pillows. I worked on manually on some areas around his spine. And he basically said he said for hours, he said he didn't have any pain. It's the first time since he had the problem happen with his testicular pain. And so we knew it was some sort of spinal irritation that was happening. But again, he ended up having a orchiectomy. He ended up having a testicle removed, which was not necessary. And he was finally on the right path, and he did much better after we were working more on spinal stuff. So even sometimes when you do lumbar or pelvic imaging, it might look negative, but there could still be something that's going on with nerve irritation at the spine. It just might not be showing up on an exam. Okay, on an imaging. So that's the important piece of this. And I'm looking to see real quick if anyone has any questions or is tuning in here. Okay, so that's a perfect example of something that can get missed. And unfortunately, that person was only given 3 options. They were told they could do the denervation, some sort of denervation, an injection denervation, and then orchiectomy. Okay. The person with the penile pain who went 13 years with the wrong treatments. I actually found he had quite a significant diastasis recti. He had multiple hernias. I worked with a hernia surgeon and had him get a bunch of scans for that. And she said there were multiple hernias that were missed that we found for him. He had significant atrophy. His weakness in his glutes was significant. He's a smoker who had a lot of connective tissue issues. So essentially, once we worked on the diastasis recti exercises specifically, we actually did strengthening of the glutes and pelvic floor. Everyone kept telling him, do not strengthen your pelvic floor. Do not strengthen your glutes because we have to do things to down train you. But when someone has pelvic pain, you have to decide, does that make sense in their case? And in his case, it made sense to strengthen him as much as possible. And then we did more testing, L4, L5, S1 manual neural testing that I do, specific kind of orthopedic testing. And essentially, he had the wrong neuralgia for 13 years. They kept saying he had pudendal neuralgia because he had penile pain and sitting pain. But it turned out it was really from hernias and spine. There was no palpation or screening in his abdominal wall at all. Because I would ask him questions, and it turns out eating would affect his symptoms, lifting would affect his symptoms, which is much more with hernias. That's why I started thinking in that path. And we really looked at a lot of other factors in terms of putting these pieces together. So hopefully that when you're seeing this, you're like, okay. So this is why I say there's hope, because someone went 13 years without on the wrong path, and just figuring out, taking some critical thinking skills and taking a step back, we were able to figure out the best path. And by the way, there are times it takes me a few times to think about it. It's not something you look at someone, you immediately think you know it. It's sometimes as testing and trials of things. And again, I have a lot of cases that are tricky for me, so that's where I work together with others to figure it out. This is another case. I feel like I saved her from a lot of the wrong stuff. She was told that she needed to go and have a bilateral pudendal nerve entrapment decompression surgery at the piriformis. They were going to resect both of her piriformis on both sides. And I palpated at her piriformis and I didn't see any problems at all. I ended up having her turn over and I looked at her abdominal area and I said, oh, it's interesting, you have a scar here. And the scar was actually quite deep. So this can happen with C-section scars. This can happen with a variety of different abdominal surgeries where over a period of 2 to 3 years, it can develop a lot of scar tissue. And as I was palpating along her scar tissue on her abdomen, she said that's when everything increased. All of her symptoms increased. So she was probably having some form of genitofemoral issue happening, an ilioinguinal issue. She did not have anything lighting up at the piriformis. So essentially I said, I'm not going to tell you not to have the surgery, but I just don't see how it could help you. I think you should consider not getting the surgery right now and see first if we can work on looking at what is lighting up your symptoms, which was the anterior area, the abdominal wall. So essentially she had 8 months after surgery, started doing increased abdominal exercises, and she didn't piece it together. She didn't think it could be the case that was the case. So when we went to her umbilicus, so her belly button area, and anywhere around here, she had stabbing pain. If you pressed, she had stabbing pain vaginally. She could not sit at all. She came to see me from, she was on a mattress. So the idea is we have to keep helping. We have to keep testing. And as you can imagine, I get frustrated because if you go to a urologist or a gynecologist, they're not trained necessarily in palpation skills. So some things, it's not because they could be amazing physicians or amazing clinicians in what they do, but they aren't necessarily trained to do this palpation. So this is why I keep saying, keep asking questions, keep trying to get to people that can help you, because you might get the best urology test or you might get the best gynecologic test vaginally, but it doesn't mean that they're looking at all components of what's happening for you. And so let's see, and then we're gonna keep moving on here. Okay, so hopefully that's helpful to know that it's sometimes finding the right combination of things to help you, okay? And just because someone says, oh, you should probably get a surgery, let's take a step back and make sure that is it actually the right, does that make sense in your case? So as you can imagine, as you've seen probably in this group, there are people who have mild symptoms. They're able to sit and work and do all things, but they just tend to have some pain. And there's others, some of my patients are basically bedbound. They have severe pain, cannot sit at all, even for 1 minute. And so there's a huge spectrum of presentation with pudendal neuralgia and pudendal nerve entrapment. Okay, and as we know, many of you are familiar, I do a sign like this. This is my pudendal sign. We have 3 branches and there's both sides. So there's 3 branches on each side of each person that has pelvis, which is all of us. So we have branches that go, and by the way, Cora wanted me to do an anatomy overview, so I thought this would be helpful. Please let me know in the comments if it is in fact helpful to go over this. I enjoy talking about anatomy and really want to, again, empower you with knowledge, and so you have more information about this. I can speak on this for a very long time. I have a course that's 30 hours, so we're trying to condense this much shorter. So if you look at the pudendal nerve, it's essentially got the three branches. You have an inferior rectal branch that goes to the rectal area and external anal sphincter and inside the rectal muscles. You've got the perineal branches that go to the more of the labial area or the scrotal area, that sort of space. And then you have the dorsal aspect of the pudendal nerve, which goes clitoral and or penile, okay? And so there's different layers to where it affects, but that's the general idea, is that it's going in three different branches. This is just more of a schematic of the areas. And the big thing to keep in mind is that the pudendal nerve is very midline, okay? So it's directly at the genitals. If someone has pain down their legs or on their abdomen, it's probably not pudendal. Doesn't mean it could be coming from a higher source. It could be that it's affecting multiple nerves, or it could be that it's just truly not a pudendal nerve. Sometimes that matters to know, and other times it doesn't. It just depends on each case. Okay. So a little trivia here, sacrum is Latin for sacred. So the sacrum and the back part is sacred. And do you know that pudendal is actually Latin for pudenda, which is shameful or disgraceful? So I always think that's just so sad that, there's a lot of disgrace around the pudendal genitals. And this is why it's so important that we talk about it and that we have no shame. We try best we can to help patients so they can navigate and get the right help, because this can be felt as to be so shameful dealing with something that's so personal and in the genital area. So neuralgia simply describes pain along the nerve distribution, okay? So it's simply a label, and I think this is really important. So saying you have pudendal neuralgia just means there's pain in the distribution of the pudendal nerve. So wherever that pudendal nerve goes in the three branches, that's essentially where you have the pain. And it's equivalent to, let me back up here, let's see, yeah. It's equivalent to if I have, and I'm going to talk about this more, but if I have pain in my head, I could say I have head neuralgia, okay? More specifically, I could say the occipital lobe or a temporal lobe or one of the nerves there, let's say a cranial nerve, there's neuralgia in that nerve near my head. But that doesn't tell me why, right? It's a label. So I want you to know that when you are labeled with pudendal neuralgia, or if you think you have pudendal neuralgia, I still want to figure out what could be the reason. Is there a reason why you're having it? Let's dig further. Let's continue to find out. Now, the other terms that are really important here is pudendal neuralgia is basically pain along the distribution of the nerve, as I shared. This can happen for many reasons. It can be inflammatory. It can be just a true irritation affecting the nerve. It can be what we call tissue-based nociceptive mechanism. So when you sit, there's compression. So therefore, you get your nociceptors that help you figure out, oh, wow, there's pain. I'm experiencing pain. That's called a nociception, okay? There's special nociceptors that help us feel pressure, that help us feel any kind of like warmth or heat or cold. So you can have receptors that you're getting picked up that go to your brain that are telling you, oh, this is painful. So your brain is interpreting it as pain. So neuralgia is essentially some sort of irritation or inflammation in that area typically, okay? Neuropathy is typically some sort of diseased state. So someone that has herpes or herpetic lesions or herpetic anything in that way. Diabetic types of problems, MS, so changes with any kind of neurological change there. Chemo changes, someone's had chemo or radiation, they might have some changes that are true neuropathy. So that's important. And then we have pudendal nerve entrapment, which is basically a physical entrapment of the nerves by adhesions, medical surgical material, or ligaments. And why this is important is most people do not have entrapment. Okay, that's the good news. Most people do not have significant adhesions around the nerve. They do not have a medical or surgical material around the nerve. They do not have their ligaments that are tight, the sacrotuberous sacrospinous ligaments. Do some people have that? Absolutely. But the majority of people dealing with pudendal neuralgia kinds of symptoms potentially are falling into more of the inflammation irritation area. And then, of course, if someone has a disease process, we do have to consider that if they have some sort of diabetes and all that. So when I tell you that some cases are very easy to treat, I've had patients that have had specific problems or pain, and they had had a shingles episode or they had some sort of herpetic thing in their past they didn't even know about necessarily. And they started on some type of a Valtrex or some type of herpetic medication, and they had complete resolution of their symptoms when they had gone for years in so much pain and agony. And so sometimes, again, just having that mindset of, in this case, does it make sense to try some sort of herpetic medicine to help this patient? So that's why the history and what we try to figure out is so important, right? So one of the biggest questions we see online that I get asked probably every day when someone comes to see me, they consistently say, do I have pudendal neuralgia or do I have pudendal nerve entrapment? Okay, and that is a very tough question because there's a lot of considerations before we decide if someone has pudendal nerve entrapment. Unfortunately, the true sign if someone has true entrapment is usually an unremitting pain, even in different positions. It's usually there's some predicated issue, like they, again, had a surgery and then they woke up from surgery and had specific symptoms that weren't there before and are unrelenting. They might have had a severe accident or injury that then immediately they started having symptoms within a short period of time that stayed. That, again, could be from the injury itself and or scar tissue post-injury. And then there's a subset of people that do have more of a congenital or problem ligaments getting tighter over time. And again, there's specific cases where you can look at their history and see this might in fact be that person. But in doing this for 25 years, there's a certain group of people that I've seen that do have that and would benefit. If they do have pudendal nerve entrapment, it would potentially benefit from surgery, but it's not necessarily the norm. Like, there's so many things we can look at for other diagnoses and or nerve irritation, as opposed to thinking that most of you have pudendal nerve entrapment. And a lot of people get really worried. I have patients that say, I'm really nervous. What if it's going to get worse? And it's not necessarily the case. There are people that can have pudendal nerve irritation for 10 years and not necessarily have any change or damage or injury to the nerves. They just might stay irritated. Okay, so that's really important. But if you notice things like you're having neurologic changes, you're having a complete change in sensation or a drop foot or something that's consistently getting worse, those are signs that there's something else going on in the nervous system, whether it's more spinal and or pudendal nerve. We need to watch for those things. But it doesn't necessarily mean if you're having pudendal neuralgia symptoms that it's necessarily causing damage long-term, okay? But that's why we have to really look at symptoms. And do you have any questions on this? I know this gets a little bit tricky to talk about, but I think it's so important because most people do not have pudendal nerve entrapment. And we want to do everything we can to assess and make sure and clear that first and make sure there's not specific things going on. There's something else called cauda equina syndrome that we also wanted to screen for. If someone has changes in their spinal, they might have, whether it's spinal pain, not always, but they might have pain. They might have problems with retention of bowel or bladder that's quick or a complete loss of bowel or bladder. They would present with something like what we call saddle paresthesias, or a change, like suddenly a major change in sensation around that area in the saddle region or genital region. Those are things, if it's more of a sudden thing, that can be an emergency, and that doesn't require going to an emergency room. So I have caught a few of those cases over the years as well. But again, most of the time it's more of a nerve irritation that people are having. But there's ways, again, we can screen for these things. And unfortunately, again, if you talk to a lot of the surgeons, they'll tell you the way you finally diagnose PNE is you do the surgery. If they really think you have entrapment, you do the surgery, you notice if they do in fact have entrapment, and then after that, you wait a year to make sure they feel good, and then you can say, yes, you in fact had pudendal nerve entrapment. So there's a lot of steps to know that, and unfortunately, that's a really tough road for people. And so the goal is to really make sure, are we on the right path with sending people for surgery versus are there other ways to do this that are much less invasive? Okay, and I'm not seeing any questions, so I will keep going. Okay, the other thing that gets confusing, and again, I could talk on this for a long time, but I'm just going to make this brief because I was there during when all this was coming out, all the nonce criteria, and it's online, so people get concerned about this. you'll see something called pudendal neuralgia by pudendal nerve entrapment. Now, I want to ask this question because I think this is important. If someone has pudendal neuralgia symptoms, so they have pain in the nerve distribution of that area, they have genital pain, does that mean they definitely have pudendal nerve entrapment? Yes or no? Can't really see an audience, but I will just answer the question. So the answer is no. They can have pudendal nerve irritation and problems there, but not have pudendal nerve entrapment. But if someone has pudendal nerve entrapment, would they typically have pudendal neuralgia symptoms? And the answer is yes, they can potentially have pudendal neuralgia symptoms. So if someone has a nerve block and gets treatment for, they're going through these tests and they go, oh, wow, I didn't have discomfort for a long time. It felt really fine. I finally have relief. It could be that you're just treating the pudendal neuralgia. It doesn't necessarily mean they distinctly have pudendal nerve entrapment. It just tells us more that the pudendal nerve is involved. But when these criteria came out, it was said that if they have for 24 hours and if it lasts long, after that period of time, then there's a good chance that they have pudendal nerve entrapment. But I'm here to tell you there are many patients that have pudendal neuralgia that did not need, in fact, pudendal nerve surgery, decompression surgery, and did really well with other ways of treating. But they did respond to a pudendal nerve block. Okay. So this is where it gets a little gray area. There are these criteria. If you look at them, pain in the territory of the pudendal nerve, pain is predominantly while sitting. The pain does not wake the patient up at night. There's no objective sensory impairment. And by the way, we now see cases where they are having sensory changes, and that means they are having some pudendal nerve entrapment. So that's changed a little bit too. And then pain is relieved by diagnostic pudendal nerve block. All of these things I'm here to tell you could be pudendal neuralgia too. Okay, but they're using the term pudendal neuralgia by pudendal nerve entrapment. So many people check these boxes and say, oh my gosh, I must have entrapment. And we've had many conversations with surgeons around the world about this that deal with this. And, there's a lot of consensus among us that we don't want to just have everyone doing surgery. We really do want to try a lot of these more conservative measures first. Okay. So I know that this can be tricky for people. Let's see here. There's a question, how does pudendal nerve affect any general dysesthesia symptoms? So yeah, that's where, again, a lot of this comes down to nomenclature and a lot of fuzzy language semantics. So this is the other thing that happens that I try to explain. It depends what journal you look in. If you look in a urology journal, they're going to call it maybe prostatitis. If you look in a gynecologic journal, they might call it vulvodynia. If you look in Dr. Irwin Goldstein's work, he'll say some sort of genital dysesthesia. So we're seeing a lot of different terms for similar kinds of symptoms, if that makes sense. And it's super confusing for everyone because genital dysesthesia has a little bit more of a neural component to it. If you look it up, I really like that they tried to tease it out more, and it has a little bit more of a definition of some of instead of just calling it pudendal neuralgia, there's a lot more definitions around it. But at the end of the day, all of these terms are similar in the sense that it could all be pudendal nerve irritation. It could be a higher up irritation. It could be that there's irritation in the spine at S2, 3, 4 nerve roots that are causing genital dysesthesia. So even Dr. Irwin Goldstein would say, even when we see a genital dysesthesia, what is being termed, it can come from a variety of sources. Is it the spine? Is it a local thing? Is it muscle tightness? It can come from multiple things. So we are using terms, but the pudendal nerve does fit under that umbrella. So if someone has genital dysesthesia, they might have a pudendal nerve issue, but they might have another issue as well. So that's what we have to figure out. That's why I'm saying there's a lot more to figure out once we get these labels, as opposed to thinking that's the stopping point. So Evelyn, I'm hoping that answers your question. And let's see, Mark is saying, if you have a finding of labral tears, it should be repaired before anything else. This has been a common condition in many patients. Is your opinion labral? Okay, so the question is, if someone has a labral tear in their history, should that be considered first before considering other things dealing with pelvic floor dysfunction or pudendal? Irritation is isolated and can be rehabilitated along with hip instability. Okay, that's a great question. I want to tell you, probably 10 to 12 years ago, there was this huge push. One research article came out that said there was a connection between people with hip labral tears and pudendal neuralgia symptoms. Okay, so lots of people were going and getting hip labral surgeries. That became a thing. Now we've walked it back a lot because if you look at the research, people that have herniated discs in their spine don't necessarily need surgery. They can get away with a lot of rehab that might actually take away the nerve irritation without needing to have spinal surgery. So the same thing is actually happening with hip labral tears. Sometimes they are incidental findings. Okay. I've worked with enough patients to know now that sometimes I can do some really extensive hip testing. Now, again, a gynecologist is not doing hip extensive testing. That's just not their training. But I can do extensive hip testing and really try to move the hip around in different ways and see if there's any kind of component. Is there potentially labral tear going on? Is there any kind of other components going on there that it looks heavy with the hip? If I'm doing a hip test and every time I do it, they say that's my genital pain, then we start to go, okay, maybe something is going on with the hip. But I've often find with patients, it's an incidental finding. They happen to have a herniated disc. They happen to have a hip labral tear. But the issue is that they just need some sort of vaginal estrogen, for example, again. So it really depends on each case. And so I think this is a fantastic question. I don't think it should be one of those things that if they found that they have labral tear, they should automatically get labral surgery. I have a patient right now who has had bilateral, I believe, bilateral labral surgeries, and he's not really that much better because I don't think at the end of the day that was his specific issue. I think there's other things going on. So it doesn't necessarily mean you have to get that surgery. It's certainly worth maybe looking at some other things first. There are some cases where someone does get labral surgery and they're a lot better. So, it can be tricky that way. Very tricky. Let's see here. I'll see if there's anything else because I'm going to answer some of these questions towards the end. So yeah, I'm going to save some of these really good questions as we move forward here. Yep, good questions. Okay, so I'm going to continue on and I love the questions. Keep them coming and then I'll answer as best I can. All right, so again, there's not a definitive. You talk to any of us that specialize in pudendal neuralgia and pudendal nerve entrapment that have been doing this for many years, you're going to find that most of us cannot definitively say if someone has pudendal nerve entrapment unless there are a few factors, okay? I'll give you one example. A big red flag is if someone wakes up from a hysterectomy, never had a single pain or problem with pudendal symptoms at all. They wake up from a hysterectomy or a C-section or some sort of surgery and immediately have significant pain, pudendal-like pain. There is a chance they had some sort of surgery issue or suture issue. Something happened that is causing them to have an entrapment. That's something that should be considered. And sometimes the surgeons will say, let's just wait a year and see if it gets better. But most of the time when it's that type of case, they should be considering going to someone that specializes in pudendal decompression or some form of surgery to help them. Those are cases that we get a little bit more concerned about. You can certainly wait a few months, but really quickly, sooner rather than later, you want to look at that. If someone had a traumatic injury where I've seen cases where they fell off of an ATV and landed on a rock, that sort of thing, when there's a significant amount of severe swelling, inflammation, and a major impact in that area, that's someone that if they can have consistently deep pain that's not getting better, that they're consistently really in bad shape, nothing is making it better at all. And again, we're talking a 9 out of 10, 8 out of 10 pain, and it's not getting better with any kind of, they can't even sleep, that sort of thing, even in that regard. But they can sleep sometimes, but often they are having trouble many hours of the day, if not all. So those are people we start to think, do they in fact have an entrapment? So there are things you can look for. There's also, like I said, there's a case of people who with sacrotuberous sacrospinous, kind of that claw area, very specific profile over the years. You can see them and go, this might be that case. But again, most people are not fitting into that. It's tricky. There are some people that probably have a claw issue and might not even have symptoms. That's the other crazy thing. So you could have that happen too, where it could be that you can see it anatomically, but it doesn't necessarily mean they have that problem. So you can see how there's, with pudendal neuralgia, there's some sort of predictable pattern. If I stand up, I feel better. If I sit down, I feel worse. They have a dull pain and it can be variable. Some days it could be a 4, some days it could be an 8. It can get worse with time. They might even feel like things are spreading, but it's not necessarily unremitting and deep. And there's usually signs that point us more towards this pudendal entrapment. But again, most people do not have entrapment. And that's the good news, is that a lot of times we can figure out there's another cause or a root issue here. So this is something I had talked about with when I teach the course, is that some patients want to know specifically, do they have that? Okay, and we talked about this already. Genital pain or sitting pain, by having pain in the distribution of the pudendal nerve, it's technically pudendal neuralgia. However, we still need to assess what the root issue is, right? You're going to hear me say this over and over again. And then often there are multiple drivers. I talk to patients about this a lot. It's like a recipe. You want to figure out, are there multiple drivers going on? Like, is it just pelvic floor that's tight? Is it that there is an irritation at the spine? Is it that they have a hernia? Is it that, there could be 3 things going on. I often find it's multiple things that are contributing. And then they might say, oh, and I'm not sleeping, or I'm really angry all the time right now because of a fight with my brother. So there could be other drivers. I had a patient who had an extremely stressful job and had rectal pain every single day. Okay. Particularly when he was at work. He had a very, very stressful job. And he said, it's really weird. When I go on vacation and I relax, I feel a lot better. So we were like, okay, so there's definitely some sort of stress component and musculoskeletal component probably going on. And then we ended up having him get some form of suppositories rectally. So again, I'm trying to work on all angles. It's not just me doing pelvic therapy. Okay, does he benefit from some form of muscle relaxer orally or from a suppository? And then we look at reducing stress factors. We look at sleep. We look at all sorts of things. And in his case, when he was doing really well, I mean, we're talking at least a 50% reduction in symptoms by changing the things that I just talked about. And then he ended up leaving his job. He ended up retiring, and it dramatically decreased. He realized that he only had about 5% of his pain on certain days, maybe once a month. So this is what I'm telling you. Sometimes the problem is right in front of you. It's not necessarily that he needed decompression surgery. We just had to change and modify some things within his lifestyle and work on pelvic floor tightness. And I did do some manual therapy there as well. So it can usually be this multimodal type of thing that goes on. And again, these are the 3 branches, here coming from the S234 nerve roots. And you can see the dorsal is going to clitoris or penis, and it affects sensory and erectile function. It affects erectile function in women as well, the ability to get aroused and to have that tissue get erect in the area. Perineal is more perineum, labia, scrotum, superficial pelvic floor. So the bulbospongiosis, ischiocavernosus, bulbocavernosus, levator ani, motor function. So the ability to contract and relax the pelvic floor. And then inferior rectal is external anal sphincter and the anal canal itself. So it can be all different layers. And you'll see here, one of the things I love to show is the traversing of I think this is a really helpful diagram to go over. So you'll see the pudendal nerve. Okay, when someone says, can I glide the nerve? Can I move my leg up and down and will it glide the nerve? You really can't glide the nerve in the same way, and I'm going to explain why. S234, so your spine, okay, if you have L5, S1, so this is the lumbar spine up here. But now we're looking at S234, so this is the sacrum. We've opened up the pelvis, so we're looking into it. The front part, we've taken away the genitals, okay? So this is the back part of the pelvis inside. So we're deep inside the pelvis right now. You have S234, and here's the coccyx or tailbone, okay? The ligaments are really important as well. So just to orient you, this is the sacrospinous ligament. It goes from the sacrum to the ischial spine. Then you have the sacrotuberous ligament, which goes from the sacrum to the ischial tuberosity. Okay. And the area where they cross is what we call a lot of times the claw. Okay. So the S234 nerve roots are coming down, and essentially they're becoming the pudendal nerve through here. They go in front of the piriformis muscle, but then they dive down underneath, and still in front of the sacrotuberous ligament, but behind the sacrospinous ligament. So they traverse, they come down, and this is where they tend to split. And if you look at cadavers, they split in different ways. It doesn't always split this way. There's multiple different ways that they can split. But a typical presentation is that the inferior rectal branch kind of goes out on its own, It's kind of hanging out, chilling on its own. And that's the inferior rectal branch on its own, going to the rectal area. But then often the dorsal branch and the perineal branch travel together. And they travel in what's called the obturator fascia. And the obturator fascia is what's labeled here where the ischial tuberosity is, the obturator muscle and the obturator fascia, so the fascia of that muscle, they travel, they basically pierce into it. This area here is called the Alcock's canal. Okay, so when you hear us talk about Alcock's canal, that's what we're talking about. So as you can imagine, someone will say, oh man, I always have pain there when I sit, and I have pain when someone touches there. So the question is it the nerve? Is it the muscle? Is it both? Is it myofascial? And the answer is you can't necessarily tease them out because the muscle is usually affected and the nerves because the nerve is innervating the muscle. So a lot of times you have to treat both. We're trying to figure out how do we decrease irritation around the nerve and also make sure the muscle isn't tight or isn't problematic. And is the reason why the muscle is tight because there is a hip issue, like we talked about? Is there a labral issue causing tightness of the muscle? Or is it that there's so much weakness around the hip that the obturator internus is having to tighten all the time to stabilize the hip? So then that's another kind of issue. We have to really strengthen the hip in order to help that relax finally. Or is it truly just working on manual therapy techniques to relax that or some combination? And then again, decreasing stress, maybe adding a muscle relaxers. There's things we can do locally to really help this area. And one of the questions is, will Botox eventually help anus pain, nerve pain? Great question. So in significant cases, when someone has, whether it's anal pain or vaginal pain, any kind of pain here, and there's a potential musculoskeletal component where the muscles are involved, particularly, let's say, the deep muscles like the obturator internus or the deep levator ani muscles, there is a chance that it'll expedite getting better if there is some Botox there because it'll relax and it just generally speaking tends to stop the muscles from consistently being in spasm. So there's a chance if that's the reason. Now, there are some patients that I can tell based on exam that that's really not their issue. Their muscles aren't that tight. So I wouldn't tell them to rush out and get Botox because it doesn't necessarily make sense in their case. So it's a case-by-case basis, really figuring that out. And again, some of that is subjective. You can go to one person that says, you should definitely get a Botox injection because it's really tight. And the others that say, this is really doable. We just have to work on the pelvic floor and get you stronger or work on a coordination of muscles and you'll be okay. So you will get lots of different opinions. And that's the tough part about navigating this. And the reason why, again, I'm here is to just give you hope that there is a way to navigate this. It's just sometimes continuing to ask the questions and empowering yourself too, and being an advocate. I'm a huge advocate for my patients. I mean, I will fight for whatever I can to get them the right help. And then I also want to empower you to do that. So let's see. Okay, so everyone feel good about the anatomy? That's what's happening. Now, what you can't see is that once the branches, the dorsal and perineal branches go through the Alcock's canal, the one goes more towards just the perineum and the other one goes towards the penis. It goes into the penis or the clitoral area. And that's the part that's hard to show in anatomy. I don't think I have some other diagrams somewhere, but I don't know that I've included them here where it shows a little bit more of where it goes. So just know that then the pudendal nerve is innervating all areas of the pelvic floor. Okay, so it's innervating all three layers of the pelvic floor. So you have three layers of the pelvic floor. It's affecting each area of that part. And then, okay, so this is important too. There are places where you can, the pudendal nerve is very deep. You can't just touch the buttocks and be like, we're on the pudendal nerve. It's actually really, really deep and takes a microscopic kind of telescoping to get down there to get to it. So it's not something you can just touch. But there are areas that become more superficial, that you can palpate or get an idea that, okay, that's maybe a nerve irritation there. You can tell, okay? And so very often if someone has vulvar pain, I show techniques of how you can actually assess the bulbocavernosus or the bulbospongiosis in men. There's a way to actually check around the perineum on the outside, and it's the perineal branches that are for some reason irritated. This can happen maybe after episiotomy. This can happen after just sitting for a long period of time, getting compression and what we call an ischemic change where there's not enough blood flow there. So sometimes it's not a major pelvic floor disorder. It's not something that requires heavy injections and things. It's just actually tightness of these muscles here. And when you work on them between, by the way, it's usually the junction of the bulbocavernosus, the part that's around the vaginal opening or around the penile shaft, and the superficial transverse perineum that goes across. Okay, it goes from ischial tuberosity to ischial tuberosity here. So that junction can be responsible for a lot of pain. And people will go for years saying, I have this bad burning and no one can figure it out. So they'll be told they have vulvodynia. They'll be told that they have, maybe pudendal nerve entrapment, but actually it's a very superficial muscle area that just needs some treatment there. And a lot of my patients in that category get much better quickly. So sometimes it's a combination. They're tight there, and they also have a hormonal component that needs to be addressed. And systemic hormones won't help. It actually has to be a local topical ointment there. And it needs to be done for a few months to see if that's helping. So there's lots of different considerations. You can also go into the inferior rectal area and palpate around the external anal sphincter. And that can also light up pudendal nerve stuff there. And again, it's because it's the primary nerve there, but there are other things. Is it muscle tightness? Is it, other kinds of factors as well? The other thing too is internally, a lot of people, I teach a lot of this, and it's not something we are taught this very often. But if you go up near the urethra in female anatomy, and you go towards the urethra and up and what we call the anterior part, so I go up this way, you can actually sometimes palpate near that urethra where the dorsal aspect of the pudendal nerve sits on that anterior vaginal wall. And some patients will say, whoa, that's all of my clitoral pain, or whoa, that gives me my PGAD symptoms. So this persistent genital arousal, that gives me all of those symptoms. And again, we can just sometimes do some gentle myofascial work, and that can help them tremendously. And they'll go for years thinking they have a major issue when it's really just a problem there. I think in some cases, what happens is someone has a history of UTIs, and there's probably some inflammatory component that's irritating the dorsal aspect of the pudendal nerves. And just by starting to get more tissue movement in that area, and sometimes the right topical cream there, it can make a huge difference. So again, just being able to palpate to figure out where is this discomfort coming from. Just saying pudendal nerve doesn't tell us a lot. We really need to figure out where on the anatomy is this happening. And then you can see, again, the deep nerves going through the but this is with the neurovascular bundle here. So you have nerve, artery, and vein that travel together. So this is the dorsal nerve, artery, and vein that travel together. Up, you can see how close it gets to near where that pubic symphysis is and where the urethral area is. It's all in that top anterior part. And then the same thing. I can't tell you how many people, how many men who have pudendal nerve dorsal irritation. If you go towards near where the prostate is and you go deep transverse perineum, so you go to where the pelvic floor muscles are, but the deep part of and then you come back near where the prostate would be, they'll tell you that is all of my penile pain, or whoa, that lights everything up. Or when I am not able to ejaculate, or when I have problems with urinary stream, it's something to do with the tightness around the prostate area, and then also affecting the dorsal aspect of the pudendal nerve locally. So if you have a pudendal nerve decompression surgery, they're going to potentially clear that area, but is it even getting the problem where the prostate is? Is it even reaching that? So that's why it's always important to try to get conservative care first, just to make sure we're clearing the entire pelvic floor around the prostate, the dorsal aspect of the pudendal nerve there. There's a lot to consider there. And I know I'm sharing a lot. I'm trying to get as much as I can in, so as much as I can. By the way, I had to block these pictures because Facebook does not like some of the pictures that I would be showing. So I had to make sure to block them. But there's a lot of treatment you can do. This is basically a bulbospongiosis or bulbocavernosus treatments that we teach on how to work on specific areas there to reduce nerve irritation locally there. And then this is one of Dr. Hibner's pictures you might have seen before, but I wanted to make sure I blocked it out. You can see there's a lot going on between the muscles and the nerves, even in the superficial. Like I was saying, there's a lot we can treat even superficially that gets missed. So there are amazing pelvic therapists out there, but sometimes, I'll say, did you treat the superficial muscles? And I'll say, oh, wait, I just did levator ani, because they've just been focusing on internally inside. But there's a lot that can happen that we can treat even on the outside sometimes to help certain patients. And by the way, there are a lot of men who are dealing with perineal pain when they sit. And cyclists, I see this with a lot of people that have heavy weightlifting routines or just sitting pain a lot. Sometimes, again, it's around penile. It's working around bulbospongiosis that helps the most, not necessarily deep pelvic floor. It's really looking at perineum and having really a heavy focus on that area itself. And again, each case is different. So I'm talking about, we go all around bulbospongiosis here. And I had to do a little, again, they're very picky about what you can show on Facebook. So got rid of some of the picture images. Okay, and then another place that you can palpate, I can go deep into the pelvis. This is for rectal or vaginal, and I can go towards the ischial spine. And again, that will light up. That should sometimes light up that is my pain I have. So then we know superficially at the ischial spine, there's an irritation, or it might also indicate that there's a deeper problem with the ischial, with the two ligaments in terms of being that claw area. But again, it won't tell us exactly, but it gives us maybe some clues if we're palpating in this area. And then also sometimes I go in and towards the sacrum itself. And sometimes that's the problem. It's at the deep sacrum, so far back at the sacrum nerve roots themselves, so higher up at the spine level. Sometimes you get this internally, sometimes you get that externally. So it depends for each patient. And I'm not trying to overwhelm as much as just tell you this is why there's so much to consider, right? It's not just a simple, oh, let's try a block and see what happens. It really helps to understand the anatomy and know what's going on. And then this is just another picture in general of pelvic floor. This is the deep pelvic floor now. We've taken away layers 1 and 2. We're in layer 3. We're looking at levator ani group. We're looking at obturator internus. We're looking at coccygeus. We're looking at any of the deeper muscles here, essentially. Okay, obturators, definitely. A lot of us that treat manual therapy a lot and deal with pelvic floor say that obturators are our favorite muscle simply because we can treat so much at obturator and help so many patients. It's really important. One of the cases I didn't go over, but I think is really important, is I had a patient that had 20 years of pain. She had bilateral decompression surgeries. She had a sphincterotomy. She had radiofrequency ablation. She had everything done. And I've never been so emotional with the patient before because I went in to do an exam and I went towards her obturator on the left and she started crying probably for an hour straight. She was just crying. And she said, "You're the first person to ever touch the pain I've been describing for 20 years. She said, "Why did it take 20 years for someone to go and touch this area that I've been trying to explain for years? Why did I get a decompression surgery? Why did I get all the other procedures and surgeries I had?" And she said, and when we started treating the actual obturator itself with the things we do, she got a lot better. And this is someone that had gone for years with this problem. So sometimes it's as simple as it really is, you know, a tightness of the pelvic floor muscles that just gets missed. So we do want to make sure we're doing that. Sometimes people make it too simple and they'll say, oh, it's just the pelvic floor, but there might be other components going on. Oh, the part, I should say in palpation, just to finish up what I was saying about parts you can palpate, you can absolutely palpate at the Alcock's canal to see if that lights up symptoms as well. So that's another area where it's more superficial. Okay. And again, that's that claw area. You can't really palpate it so much, but you can, what I do sometimes is I take patients into a position and lift their gluteal area. And sometimes that makes their symptoms a lot better. And so we kind of know that, all right, whatever we're doing to take pressure off and around the sacrotuberous ligament is helping. But it doesn't necessarily mean they have an entrapment. It's just that one way to treat in that area. And we also have to remember, and this is super important, there are other nerves. Okay, I can't tell you how many people thought they had pudendal neuralgia when they had a high hamstring tendinopathy happening. I saw a patient recently who had surgery for pudendal, but actually, as soon as she started telling me her history, I knew it was actually really it was a high hamstring tendinopathy going on. So she was being treated for pudendal, but it was high hamstring tendinopathy the whole time. There are people that have more of a sciatic problem where there is a piriformis tightness or a sciatic problem coming from the spine. And they will pick up some pudendal symptoms because the pudendal nerve is coming, it's literally coming out. I mean, it's coming close to that area. So it might pick up both nerves, but the primary issue is actually a sciatic nerve issue. So again, we want to just make sure we're not missing it because we're focusing just on pudendal. There's a lot more to look at. This whole person, we want to look at the whole person. And again, I know a lot of you have seen these diagrams by now, but just to reiterate that there's a lot of nerves in the pelvic region, okay? So we have to figure out, sometimes it matters the specific nerve, and sometimes I'm treating the patient that's in front of me, and it doesn't matter what nerve it is. We're just gonna work on tissue mobility, get them moving better, strengthening, whatever it takes to get them feeling better. So sometimes the nerve doesn't matter as much. Other times we want to be specific because we're trying to figure out, do they have a spinal problem? Do they have a local peripheral pudendal nerve problem? We do want to sometimes figure that out. It just depends on each case. And again, you can see all the different nerves here. I'll just let you look at that for a second. I'll take some water. Are you finding this helpful? I'm really hoping to share anatomy and just get you understanding of all the things that you can look for or that can be looked at instead of just assuming that you might need to get pudendal surgery. There's a lot more to look at and figure out. So let me know if this is helpful. Okay, so someone asked a question. Diane is asking, do you believe in neuroplasticity? The short answer is yes, and I'll tell you why. My actual undergrad was in neuropsychology and neuroscience, and I thought I was going to be a neuroscientist. And so I was really fascinated by the brain. I used to read all the books on brain and neuroplasticity, and actually did one of my papers on neuroplasticity of the corpus callosum that connects the right and the left side of the brain. And I went on to schooling, got graduate degrees, went on for schooling, ended up doing pelvic health. So I thought I would never use neuro again. And as it turns out, I'm now teaching a lot on neuro and the brain because there's a huge component of brain and pain and neuroplasticity and changes. So yes, I really believe that most people, if they are having a lot of pain, there's a way to figure out how to calm down the nervous system, and try to see if you can work on neuroplasticity components to get that to calm down. Now, again, it depends on the reason why they're having the discomfort or pain. But often, if you're working at a nervous system level, you can help many patients with changes of the brain at a higher level. I'm really big on not just saying, hey, it's just in your brain, because that sounds like you're just saying you're making it up or it's not a big deal, just don't think about it. It's much more complex than that, in that we're really trying to downregulate the entire nervous system and getting things to not hurt. So we do a lot of desensitization strategies where I might touch the person to the point where they don't feel discomfort and then go closer to the area where they do. There's a lot of desensitization strategies so the brain starts to not go into an immediate protection mode. So there's a lot of desensitization I do with treatments. So yes. This is something we do in our labs for courses. I just wanted to point out how many things we can look at: bladder pain, urethral pain, cervix pain, coccyx pain, rectal pain. We're looking at a lot that encompasses pudendal, right? It's not just one thing, it's multiple things we're looking at. Someone had asked techniques to treat tailbone pain. Absolutely, there's lots of techniques. Is it coming from the coccyx itself? Is it coming from tailbone, like just mobilizing the tailbone? Is it coming from the pubococcygeus? Is it coming from coccygeus muscles? Is it actually a colorectal case? I had one patient that had an abscess that was missed. So if it's a rectal abscess, I can do all the best manual treatment in the world, but the underlying issue is that they had a rectal abscess. So we have to keep looking at all the medical conditions it could be, but then also, is there a tailbone issue? And I think I actually have a really good slide. Let me see here. Yeah, this is what I want to show you. Good timing. There's something else that gets missed a lot. I don't know if you can see, this is actually around the anal area. So at the bottom here is the anal rectal area. This area is when you open up the cheeks, the bottom cheeks, it's called the gluteal cleft, okay? There are a lot of people that have sitting pain and tailbone pain, and it's actually a problem with the connective tissue. You see how red that is? It actually, if you keep separating it, it almost tears. It'll get like small tears. You'll actually get a little bit of bleeding because it can get so tight. You can actually get, I don't know if you can see, there's a little divot here. So there's there's this big thing called pilonidal sinus, which can get infected. But it doesn't necessarily have to be a pilonidal sinus. It can actually be a small pilonidal dimple. So you can have dimples here. And what happens is the connective tissue gets super tight around there. So someone will say every time they sit, they have severe tailbone pain or discomfort. It feels tight all the time. And in all the years that they're getting help, you think about it, a urologist isn't opening up the gluteal cleft. A gynecologist isn't opening up the gluteal cleft. A neurologist isn't opening up the gluteal cleft. And even most pelvic PTs don't think to open up the gluteal cleft. And so this is what we try to teach a lot more of, is opening that tissue up. I've had professional athletes I've worked with who had severe pain with sitting and had trouble. They were doing a lot of, they couldn't do their career anymore because they were having so much pain. And you start working on this area, getting tissue mobility, getting the tissue healthier and moving better. and it can be a complete resolution. It was never the tailbone that was the problem. It was actually this connective tissue here. So again, I showed just an example of all the different things it could be, as opposed to thinking it's just pudendal neuralgia. That's just the label. Okay. I do have a video. It's funny. I have a YouTube video that I did just to show a demonstration about it. I think it's called like, if you look up my name, Pudendal Neuralgia Technique or something like that, it went and got like over 1 million views before it finally made it look like adult content, because it looked like I mean, I was in there working on this person. But you can see the technique and what I do for this kind of thing in terms of the tissue mobility that I do. That is available somewhere out there in the world. I haven't seen it in a while, but I know it's out there. Okay. So let's go back one. Okay, so blocks and injections. That's a question that comes up a lot in this group. And because I don't do blocks or injections, I don't want to misstep and say something that I'm not comfortable in, it's not in my scope. But I will tell you, a lot of people, the larger piece that I can give that people ask is, should I get a block? Should I get a pudendal nerve block? Should I get a posterior femoral cutaneous block? Should I get a ganglion block? Should I get a sacral block? There's so many different blocks out there that they're asking about. Should I get an L1 block? Should I get an ilioinguinal block? The tough thing is even if you got the best pudendal block, what are we doing with that information? Sometimes a block can be treatment. So someone will say, when I get a block, I feel good for 2 months. Then I say, if that really helps you as part of this, whether it's diagnostic and or treatment, it's part of the thing that's helping you, then great, that makes sense. But if people are chasing things like, let me do this block, let me do that block, let me do this block, my question is, even if it turned out that you found out it was pudendal, we might be doing a similar treatment anyway. So it's diagnostic. And if you want to get that information, that's great. But I don't necessarily have people rush out and get all the blocks right away. Some people, in fact, do find that they get the right ganglion impar block and they feel great. So again, if they do feel that, it helps us to know that it could be coming from the spine. And we also know that that is something that's helping them. So it does guide our treatment a little bit. But it's not, I don't make patients immediately go and get all the blocks and all the injections. Okay. There's also lots of different injections out there now. There's trigger point injections, there's Botox, there's stem cell types of injections. So there's lots of variables there too. And again, it depends on what the problems they're having. If someone does not have tightness, like I was saying, you don't necessarily need to rush out and get Botox. If they want to try stem cell, they can certainly try it. But again, the research, I just don't know that it's there yet to support that. But some really believe in it and see that their patients get better. So I think it's a personal decision. Does that make sense for you in your case? And that's where we kind of work together to figure that out. So yeah, so that's a big question that comes up quite a bit. Let's see. Ingestative penis. Okay, I'll look at those in a moment here. I'm gonna go through this. A lot of questions come up about exercise in the group too. And the overarching thing I can share about that I think is super helpful for you to know is that, if they say like, never do a squat, never do this kind of exercise, and that's not true. There are people that actually feel really good getting into a deep squat because what it does is actually opens up the pelvis in a way that takes pressure off of their pudendal nerves or that area in general. So I tell them, if that feels good for you, go for that position. That will be really helpful for them. But if every time you do a squat or you do a single leg lunge or you do even a bench press, whatever it is that keeps irritating your symptoms, it doesn't mean you won't be able to do that again one day, but it means that you shouldn't necessarily do that now, or we need to scale it. So if someone's doing a heavy weightlifting squat, a back squat, okay, and they're coming down, every time they do that, they feel pain then or a day later. What we want to do is let's do it without weight. Is that better for you? Or let's modify it. Let's have you go down just a little bit and see how that goes. Or let's take that exercise out for now and give you 2 other exercises. So the biggest thing with exercise is movement is really good for you. It's figuring out what movement isn't irritating your particular symptoms. So I hardly ever say don't ever do any exercise. It's figuring out what the right exercise is that you like to do, and that ultimately doesn't give you flares every time. A lot of people say, forget it, I'm just not going to do anything because everything flares me up. Well, then it's like, okay, I challenge them a little bit. Is it that everything flares them up, or is it just that they're doing too many reps or too much of the wrong exercises? I want to look at that a little bit more. So there's not a definitive thing, but a lot of times people with pudendal tend to have problems with squats. So if we're considering that, we might back away from that. Someone in one of the questions said every time they do a clamshell exercise, they get really flared up. So again, I would question, do we just need to take that exercise completely away right now and do it later? It's also a hip external rotator you're working on, so that gives me more information. Do we need to figure out another way to calm down your hip external rotators and strengthen as well? That isn't putting you into that rotation position first. So there's lots of things to look at. I think there's a lot you can scale or change depending on your case. Okay. So no, technically no unsafe exercise, but some that are irritating. Oh, that's the other thing. People think that if you're doing an exercise and you continue to have symptoms, that you're doing damage to the nerve. That's typically not the case. If you're doing an exercise and you suddenly have nerve, like a drop foot, or you notice like severe numbness of your leg or complete numbness of your genitals each time you do the exercise, those are red flags. Then we need to really like figure out what's happening when you do that. But if it's just simply you do an exercise, you get a little flared up, it does not necessarily mean you're doing damage to that area or the nerve. So I think that's a really important distinction too. And they've done lots of studies on exercise and shown that there's no evidence that one particular type of exercise therapy is more effective than others. And this is across back pain, pudendal, any kind of studies show that it's really movement is really important and just getting them stronger in whatever way that is at their own pace, mobility and strength. Okay. And I do have, there are relaxation techniques for the pelvic floor. Unfortunately, I don't know that we'll have time to go in this in detail. I didn't set something up, but if you all are interested, I can ask Cora later if you want me to give a link where I can basically maybe get this type of worksheet for all of you. If you want to sign up for that, we can potentially do that. I didn't do it this time, but if this is something that's of interest to you to get maybe some resources like this, I'm happy to share that with you. We have it available. Okay, and so again, the pudendal nerve is pretty deep in there. So you can see that this is a surgery where Dr. Hibner basically essentially this is a sacrotuberous ligament that's been cut, and they have to go dive deep down to get to the pudendal nerve. Now, unfortunately, I can't show you because I think it won't let me do it in Facebook, but you can see that there's a lot of muscles and layers of fat. Here, this is all adipose tissue. This is fat. You've got the skin on top. There's lots of layers to get through to get to the pudendal, so you can't just touch it on the outside. And I do a lot of, again, that gluteal cleft stuff where I lift up the buttocks to see if that can help. Gentle, and we talked about neuroplasticity. Even if someone just feels better for a moment, maybe even 10 seconds, I know that that means there's a good chance they can start feeling better. If we can figure out a way to move the tissue or have them move or change positions that seems to calm down their symptoms, that's a good sign that they will, in fact, have a chance of getting better. That means that there's some neuromodulation going on there. Okay. And we do a lot. I mean, sometimes we have to do rectal treatments. So we have to look at each case and decide. Lots of muscles here that we're also looking at. And, like we don't talk about this enough, but I have patients that have specific problems with their adductors where they have an obturator nerve issue that's coming out of the obturator foramen here. So it's not pudendal nerve, it's actually obturator nerve. So sometimes they've been treated for years for pudendal nerve when actually there's another nerve that's being irritated. So again, it's just figuring out the anatomy. Okay, so this is what I'm going to do. I'm going to look at some of the questions you're asking here, but there were also a lot of questions already turned in. So this would be a great time if you want to ask any questions in the chat. I'm happy to start fielding them. I won't be able to cover all of them. Simply some won't be appropriate to cover. Some I just can't get to all of them at some point. And then I'm going to go through some of the other questions you did submit, and hopefully we'll land where everyone feels good about it. Let's see. Start going through these. Yeah, definitely our heart goes out to all the pain warriors. I'm telling you, in doing this for 25 years, I've felt such a calling to making sure people can get the right care and advocate for themselves. And, you deal with so much with this problem, and it feels sometimes like no one's listening or you're not able to get the right help. Care can be so compartmentalized, right? So you have to go to this person for this condition, part of the condition, and this person for something else. And it is such a frustrating path. But like I said, there is hope. It's just figuring out that path. And unfortunately, sometimes it is a little circuitous, or feels like it can be, but there are ways to continue to get the answers as best you can. That's why we do all these questions. And I love that Cora has asked me to come on to help you so that we can see if there's any questions coming up for you. Okay. So some of the questions that came up, at what point, or does she ever recommend decompression surgery? Do you feel like I've answered that enough? I want to say that it's really the rare cases that you need decompression. I will say there's a little bit of a difference that's happening now over the years. Okay. I was seeing decompression surgery patients, a lot of them probably 13, 14 years ago. That was at the height of when they were doing a lot more decompression surgeries. And not all of them were successful. And there were some cases where it was like, man, we should have tried some other things first. So I think we've gotten better at helping the surgeons figuring out which cases are probably for surgery or not. And then there's so many different variances in how they do them, from the, decompression transgluteally, then you have laparoscopic cases. So even then it's figuring out, is the surgeon the right person for what my problem is? Is a laparoscopic better in this case, or do they really need to go transgluteally to get to it? And again, it's going to depend on your symptoms, but most patients, again, are not going to need decompression surgery. And when I'm so excited when I see someone did get decompression surgery and they're doing a lot better, I'm so happy for them, because I know at that point that they did get it, it was something that, did seem like the right thing for them. And then I know I work with a lot of patients who have had decompression surgery, and unfortunately, there were some considerations that, or consequences where they were not feeling like it helped. So, I've seen all variances of that. Okay, what specific exercise stretches does she suggest for patients with entrapped? Okay, so remember, most of the time, the nerves are not entrapped. So exercises are going to be anything that's mobility based. So movement, walking is great. Moving the legs and arms in different positions, just opening up thoracic, like getting some nice movement of the spine, gentle movements of the legs, and basically you can start doing some strengthening, but just see if it doesn't flare you up. Now, this is where there's so many exercises you can give, from gentle bridging to taking it higher level, where you are doing mini squats, where you're doing leg lifts. There's all sorts of things I can give you. There's not one specific Pudendal protocol. I've tried put together post decompression surgery protocols before, and there is a nice progression you can do for that. Same thing if someone's really in distinct pain every time they sit, and I'm telling them to get up every 20 to 30 minutes, making sure you are getting compression out of that area, and then doing some nice mobility work that isn't causing you to flare. So it's more gentle movements. And then if someone wants to go higher level, as long as they're not flaring. Some people run and they're fine as long as they run. But when they sit, they have pain. So I tell them, don't stop your running. Don't stop the things that you love to do. And even for people cycling, like if they want to get back to cycling one day, I never say, you won't do that. It's just a matter of scaling them, seeing if they can slowly start getting back to that when they're ready. I've had some success with patients who did start doing really well with cycling again, which is really exciting. What are techniques in PT to help with the sit bone pain? So that's a combination. Okay, that's going to be a combination. We can go with cushions. We can go with decompression in terms of not surgery, but of like off lifting and doing some things to take pressure off the one sit bone, or both, depending. It might be actual manual therapy in the area. It could be, like I talked about, sometimes that gluteal cleft really helps to work on the tissue there. It could be getting muscle relaxers to the area, suppositories that help with that. So there's multiple things to look at in that area. It's really person dependent for each one. I do some tests where I actually have someone sit and I go underneath their tailbone, their tailbone as well, but I go underneath the ischial tuberosities, and I'm trying to figure out, is it actually a problem at the hamstrings? Is it a problem at the medial aspect of the ischial tuberosity, where the Alcock's canal is on one side or both? I'm going around the tailbone. I'm going around the hip bones. I'm trying to figure out, where is that sitting bone pain coming from? Is it actually the sit bone itself, or is it actually some other variant nearby that's actually causing it? So sitting and doing testing really can help as well to figure out where that's coming from and why. Let's see. Have you had patients who had success with internal work on the obturator internus to the point where the symptoms are minimal? Yes. Sometimes it's simple cases where we just work on obturator internus and other deep pelvic floor muscles. They do great. Other times we have to start adding things. So you won't always see these cases coming on into this group to say, hey, I had 4 treatments and I'm now so much better. You won't see those cases necessarily. So it's important to know that there are people that do get better. So I think I already touched this, right? Exercises you should avoid. There's not necessarily one exercise. It's more, does it flare you up? Is it that the symptoms get much worse when you do them? Then we need to modify it or take it out for now. Is it possible for PT to help with allodynia to the point where I can wear underwear or jeans again? Yes. And the question is, why are you having that allodynia or sensitivity to even having clothes on, underwear or tight jeans or any kind of jeans? It's figuring out why. Is it just a desensitization strategy, or are you having a nerve irritation from some reason? Is it hormonal? Is it tightness of the pelvic floor? Is it that you have some sort of scar tissue there? We have to figure out why you're having that irritation. And then there's distinct desensitization strategies you can do for that. We introduce touch to that area in different ways to get someone used to being able to wear stuff again, underwear or jeans. And then let's see, since pudendal neuralgia can't be diagnosed for sure, does it make sense to keep getting tests for other conditions? I think that's where it gets tricky. I see some patients, like I talked about earlier, doing a pudendal tour, where I feel like they're going all over to all different specialists and getting all these tests. And sometimes I have to kind of pull them in and say, wait, some of the tests you're doing don't even make sense. Like, and I never make someone, I try not to make someone feel bad about it, but it's like, let's see if I try to help coordinate, like what makes the most sense for you. If you have this kind of pain, you probably don't need to get a test on your hand right now, right? For example, or you don't need to get a test on your foot. So I try to help them, guide them on what makes the most sense, because just getting a bunch of tests doesn't necessarily help. It's the right test at the right time. So sometimes we have enough information without tests, and sometimes the right tests really make a difference. I had a patient who thought he had significant pudendal nerve entrapment, and he technically did. He had suddenly more numbness in his penile area, his whole penis, and then just even in the genital area in general there. He had a change, like more coldness there in that area. And he said, well, I guess I'm getting older. I'm in my late 20s now. So maybe my erections aren't supposed to be as good anymore. And I'm like, no, that doesn't make sense. Like, you're not having erectile changes. You're having penile pain and more like sensitivity there. And I kept testing something that didn't seem right in that in the inguinal area. So I thought maybe he had a hernia when I was testing there. And it turned out he had entrapment of the nerve via a tumor there. There was a tumor sitting there. So once he had the tumor removed, it took a while because the nerve had been compressed for a long time there, but he actually, over a year or two, you get regeneration of the nerve, and he actually got full function or most function back. So, we have to, that makes sense then to get testing to see if there's a hernia or some other kind of tumor or something there. So instead of just saying, oh, let's just keep working on your muscles, or, oh, let's get a spine test, we have to also put the test to what the issue could be. That's the most important thing, is matching the tests to what makes the most sense from a critical thinking standpoint. So yeah, so that's some of those answers. Let me see what else. I really appreciate you asking questions, because it helps me understand what you really want to know. And I'm trying to ask as much as I can, or answer as much as I can here.
So
Let's see.
I have a question for you. So
Yes.
somebody asked, I presume they mean transgluteal decompression surgery, but when you have that surgery and they cut the sacrospinous ligament, um, do you see that when you do exams on patients, and do you see it complicating anything like pelvis stability or anything like that? But
Um,
what are your thoughts on
Yeah, the biggest thing that seems to happen, because I've seen a variety of pudendal decompression surgeries that are done, particularly the transgluteal ones. And the thing that I see that happens the most is atrophy of the gluteal area. So it feels like if you can strengthen the gluteals as best as you can, sometimes that actually is a way of compensating for any changes at the sacrotuberous ligament itself.
it?
Um, but there has been a disruption of the area. So it is going to be maybe not nearly as strong as it was in their past, but there is a way to strengthen around the area to at least make it more stable. I think there's this idea that, oh my gosh, I'm going to be completely unstable. And it's not, you'd be surprised. Some people go back to a lot of things again, as long as we continue to really strengthen around the area. But I think I'd be wrong to say that you don't notice some instability or some changes there. In terms of the glute, especially the glutes tend to be the most where we really have to work on those a lot. So yes, there can be some intrinsic type of sacrotuberous issues, but it's really the whole complex, really that gluteal area that I see the most with decompression.
And then there was a question about CRPS and how it correlates with PN.
Okay.
Um,
Yeah. So this is where also I wish so much. I'm so glad again to have this platform to share this because, okay, so complex regional pain syndrome, CRPS, is essentially, they use a lot of the literature came from hands and feet. And the idea was someone's having significant pain that's not in proportion to what it should be. So, for example, I stubbed my finger, my toe is what I was going to say, but I hit my finger against here. And it should have just been like, oh, that hurt. And maybe over an hour it gets better. But now, 3 days later, I have significant redness and it's the worst pain of my life. Okay. And that continues for the next year. That can be a CRPS type of reaction. It's allogenic and it's very significant, like way more than it should have been for the injury or the problem that happened. Okay. So, what was the question though about it? CRPS?
it was just, hold on, sorry, I lost it. How it
Okay.
correlates with PN.
Okay, so some people, okay, so it gets frustrating for a lot of patients because they're told, oh, you just have central sensitization now. You just have CRPS and you're just going to have to deal with it. So it is true that if you have certain kinds of pain, there is a connection between the brain and the spine, and you can become hypersensitive to an area. The nice thing, like I was talking about earlier, is the neuroplasticity, and you can actually desensitize almost any area that's had problems. So if someone has a CRPS type of reaction, yes, in the pudendal area, they can. I do see some patients that have significant, like almost, again, you can't even touch the area or they have significant pain. And then we start to say, if it's that significant, is that where they have a condition that is being mediated by, there is an entrapment there? If it's so significant all the time and there's no way to mediate it down immediately, is that something that's saying they do have an entrapment, or is it a form of central sensitization or and peripheral sensitization too? They might have it down the nerve as well, peripherally. Is it a form of CRPS? And that's where, again, you can work on desensitization strategies to see over time, is it getting better? If you're doing all the desensitization strategies and all the strategies we know to do from a top-down approach and it's not getting better, you've tried peripheral treatments, then you got to look at the history. Is this someone that had a hysterectomy? Is this someone who had a major trauma incident? Then you start to think maybe in this case, it's not just CRPS as much as there is an entrapment. So there's a lot of clinical reasoning to think about. But yes, someone that has pudendal nerve issues could potentially have a form of CRPS. But there's lots of gray in there, what other things could be going on.
Okay. And there was another question. I know this is kind of a general, but what are techniques to treat tailbone pain? Um, I noticed a lot of feedback from people in the group saying that tailbone pain is one of the hardest things to treat. So maybe the question is, have you had that in your experience? Is tailbone pain very difficult to treat, or do you find that it's usually like a coccygeus muscle, for instance, that's causing a lot of that pain for a patient? And is that something you can help?
Yeah, so I did talk about that earlier. Essentially, there's a lot, yeah, we can definitely look at. And when I talked about that, the pilonidal area, the gluteal cleft area, that's an important piece. Is it connective tissue on the outside near the tailbone itself? That gets missed all the time. Is it internally? Is it the coccygeus muscles? Is it, there's times when I can actually go internally. I tend to use my fingers a lot for this stuff. I go internally and you can actually feel that the coccygeus muscles are so tight, they're holding onto the tailbone for dear life, if so what it feels like. And so figuring out, is this someone that actually needs a top-down approach where we do oral, they do some sort of oral muscle relaxer plus internal treatment? Is this someone that'll benefit from a suppository that has a relaxer and then we do manual treatment? Or is this someone we can just do manual treatment, work on those muscles and work on mobility of the coccyx, and they actually start to feel a lot better? So that's the tricky thing, is that I thought I had a model. Maybe I didn't have it with me. I meant to bring my model here. But essentially, yes, it's all of those above. It could be that we just need to work on the muscles. It could be we work on mobility of the coccyx. The hardest cases is when the coccyx has been actually a form of dislocation, where we do have someone who's a specialist, Dr. Foy up in New York, I believe. He specializes in really significant tailbone issues. So sometimes I'll have them do a consult just to see, from an imaging standpoint or something, is this someone that has another issue where they need some form of injections there? Or do they need other kind of surgeries to do things? I usually do not recommend. I haven't seen very good scenarios with coccygectomies where they do basically a cutting of the tailbone. That seems to not necessarily, if someone has tailbone pain, correlate with, oh my gosh, now I don't have any tailbone pain. So we have to look at all the muscles. We have to look at the muscles. We have to look at the whole complex there. We have to look at the external tissue. And then sometimes we do have to look higher up on the spine. Is there something going on there? So but it's, to me, actually, a lot of those cases get better. It's just figuring out what the actual underlying issue is.
So for patients that have recurrent UTIs and they use catheters, and they remove the Foley, and it causes them a lot of pain in the rectum. Can you explain why that might be?
Okay, so I just want to make sure they're having UTIs and they're using a
Yeah.
catheter
Yes.
and they're having rectal pain.
Yes. For some reason, when they change it out, they're having severe PN pain in their rectum.
Yeah, I mean, that's such a specific case. Like, it's hard to know. It's obviously irritating. It's actually I know the answer is, it's somewhere near one of those that, I talked earlier. I don't know if that person was here when I talked earlier about the prostate being close to the pudendal nerve,
Mhm.
right where that area is. So the prostate is probably doing something near the nerves near the prostate. And so that's all, it's essentially irritating from a urethral standpoint, but it's affecting the near the prostate probably and the nerves in that whole complex. So maybe the dorsal aspect of the pudendal nerve. Um, it's hard to know. Again, I'd have to know specifics and palpate and all that, but it's probably some nerve irritation that's happening at the urethral level, but it's affecting down the chain to the rectal area. Again, it could be inferior rectal branch as well.
Okay.
So it's tricky to know, but it makes sense. You do see that where something in one component of the pelvic floor is affecting something different in a different area.
Like referred pain or something
It can
like that.
definitely be a nerve irritation that way too, for sure.
And so
Especially
this is
if it's consistently happening every time, you go, okay, that's distinctly a nerve irritation happening. It sounds like something like that, but I can't diagnose like that.
right. So this is a general question, just so because I know we get this question a lot. If do you have a way for members to find a good PT in their areas? I know a lot of people kind of asked questions like, hey, like I can't travel,
Right.
right? And I need
Right.
somebody close by.
Yep.
Do you do any therapies? Because I know it's hard without like a physical exam. Is there any other options for those people that are bedbound that cannot go?
Yeah.
Or ways
So, oh, go
maybe
ahead.
sorry, or maybe ways like they can find a therapist that can come into their home. I don't know if that's an option or not. So,
Yeah. Okay. So there's a few things. It's funny that I just happened to put the slide up, which is, so what happened is this is what I run, Pelvic Global Academy, Pelvic Global. It's basically an education company for professionals. And we do a lot of resources for professionals. And I teach my Pudendal course through it for professionals. So we do a lot of professional training. And so over the years, we have a community of people that have entered their information here into this. It's pelvicglobal.com, and it's a global directory of all pelvic health professionals. We have physicians in there, physical therapists, nursing, nutritionists. We have all sorts of people in the pelvic health space that have put their information in. And so you can check that out and see if there's someone in your area. You will still probably have to interview and ask. And some people say, well, what do I ask? You want to make sure they specifically have been trained in pelvic pain, because there are a lot of pelvic health professionals that have taken level 1 or level 2 and might know a little bit about incontinence or, you know, uh, bowel incontinence or bowel function, constipation, but might not know a lot about pudendal and specific questions for that and pelvic pain. So you want to make sure someone, and it doesn't necessarily, they don't have to be certified per se, because there are people that have been doing this for 20 years, 30 years that aren't certified, but are very experienced with pelvic pain. They've made their entire career about pelvic pain. So you're going to have to probably interview or look online and see. They might even have a blip about, I specialize in pelvic pain. So they might actually say what they do. We also added a section that shows you what courses they take, but it's newer, so they might not have done it yet. Where if they've taken my Pudendal course, for example, or other pelvic pain courses, you can get a sense. So hopefully that's helpful. Now, in terms of do people come to your homes, There are more and more pelvic health professionals that are starting mobile practices now where they will come to people's homes. So you can certainly ask. I don't personally at this point go to people's homes, but there are people that will in certain areas go to people's homes and they have practices set up to do that. Sometimes they're only doing that for pregnancy and postpartum, but some of them are actually very well equipped and knowledgeable to deal with pelvic pain. So that is an option to consider. They might do that. Then there's a lot of us that offer telehealth. So what I do with my telehealth, and again, I know I have a wait list and it's challenging, but what I do with my telehealth is I act kind of like a case manager of, okay, they'll say, I have these problems. I can't necessarily diagnose, nor can I treat over online. But sometimes they'll just say something. I'm like, oh, I know exactly where you need to go in your area because I have a lot of connections and know people in different areas. Or I'll say, what I need you to do, I think it'd be really helpful in your case to get these 3 tests potentially. So, again, I can't diagnose, but if you get these 3 tests, we'll have a much better idea of what's happening. So sometimes I can just guide them on what the next best steps are, as opposed to treating them per se, but there's a lot we can maybe offer in terms of a consultation of what to do next steps.
Okay.
So hopefully that's helpful.
So this one is a little bit long. It's a multi-question, but they're sort of related. So I'm just gonna throw it out there. So if the obturator is tight, does it require strengthening all the time or just releasing the muscle? And how long would something like this take to see if they're like it's working? Like how long would you have to go to PT to see if it's working?
Okay, so was the original part that it's tight?
Yes.
Okay, so they have tight muscles and they're supposed to be doing strengthening or relaxing and they're trying to figure out how to get better. Um, That's a great question. And similar to what I had shared earlier, but now to put it in the context of these questions is with muscle tightness or any kind of muscle dysfunction, we should know usually within the first 4 to 6 visits if we're on the right track. This is where it also gets tricky. There are people who mean well, but just aren't trained in pelvic pain or tightness of muscles. So they might be implementing things that are meant for more people like that need to strengthen more or tighten more. So if you're finding someone is only giving you, for example, lots of pelvic floor exercises and having you squeeze, 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 it might be that it's not that physical therapy isn't working. It's that you're just not at the right location or the right place for their expertise. So it's figuring out how to make sure you're first in the right location. Secondly, usually, like I said, within 4 to 6 visits, we kind of know if we're on the right track. And then we can see, do you also need a muscle relaxer? Do you also need something else? We can start to tweak things like, do I need to give you more exercises with gentle opening of the pelvic floor instead of having you strengthen? In some cases, it might be, yes, you're at a point where we can start strengthening you now. Let's see for the next 6 weeks how you do with this program. So it takes 6 to 8 weeks, typically 4 to 8 weeks or so to strengthen properly. So in terms of if we are doing a strengthening part of this component, it would be a certain amount of, it could be 2 to 3 months there. If it's really super tight and it's not changing, then we have to figure out, is there another reason why? Is there something that's contributing, down the line? Are we looking at the whole person? Is there something being missed? If they're holding their glutes like this all the time, every day, we call them butt grippers. So if you're holding your glutes all the time, you're tightening, you're barely breathing and you're tightening all the time. I always say this, I don't know if you can see this, but embryologically, if I wanted to tell someone to really have a tight, tight pelvic floor from an embryologic standpoint, I would tell them to go like this, basically tighten their jaw as hard as they can. I would tell them to clench their whole body, close their eyes as tight as they can, clench their buttocks, and put their legs together as hard as they can. That is going to fire up the pelvic floor like crazy. Okay, so the exact opposite is actually having everything open up as much as possible. The legs open, the arms open, the eyes open, everything, no jaw clenching, putting your tongue on the roof of your mouth, everything you can to open up and being in the most relaxed position you can get in, whether that's on your side or back with support around your legs, that's going to help relax the pelvic floor. So it's not just what you do in the clinic, it's what you're doing outside of the clinic to help relax the pelvic floor. It's working on stress and sleep and all those components too. So it's not just, is physical therapy working? Are we putting enough components together to help this person get better? And then slowly strengthening where they need strengthening as well. So I'm hoping I answered the question. It's really, again, individual, but usually in the first 4 to 6 visits, I have an idea if I'm on the right track. You shouldn't have to wait 2 years or so and be like, oh, I'm still not better. We should know pretty soon in the first few months.
So I know you kind of covered this one. Maybe they weren't here in the beginning, but what happens when everything flares you? And at what point do you just decide to, like push through the pain, so to speak, to see if things improve for you, or do you modify? And even if you modify, if it still flares you, is it just, would you suggest something more like walking or something like that to start strengthening?
Yep. So this is where it's okay. Sometimes we use, I don't know if this is the best example in this case, but I'm going to try it. If there's okay, so there's an iceberg here, okay, and someone will say every time I do these things, I almost get to the point where I'm an 8 or a 9. I'm about to hit the iceberg. I'm here. My question is, let's first take you back. Is there anything you can do that keeps your discomfort at a 1 or 2 or 3, whatever that is for you, their lowest baseline? If their lowest baseline is a 4 out of 10, it doesn't have to be a 0, but what's the thing they do that keeps their level low? So let's say it's lying down, relaxing, that keeps them at a low level. Okay. When someone says everything I do flares me up, my challenge is to figure out what they can do that keeps them, maybe only flares them 5 to 6. It doesn't go all the way to the iceberg. We're not, but are you at a 4 and we're okay with you getting to a 5 and then you need to back it up. So that might be 5 minutes of walking at first. That might be 5 minutes of, raising your arms and doing some things standing. We try to figure out something that they can do movement wise that does not flare them up more than 1 or 2 points, if that makes sense. Like it's okay to flare a little, but then come back down and then get back into a rest position. So instead of thinking it's all or nothing or everything flares me up, my challenge is to figure out what won't flare them up and to work together with them on that. Or to a relative flare, but not to the point where they're getting to that level of no return where they have to spend 2 days now recovering. So there's this art, there's definitely an art to exercise with this stuff. And that's actually why I enjoy what I get to do, is trying to figure out what that is for each person.
And I think you also answer this, but just in case, are
Okay.
you still actively seeing patients?
Oh, okay. Yeah, that's a good question. My days are limited now as I do a lot more teaching and working on the education side of things. But I do have, technically, yes, my practice is still open. I do have months of wait list for in-person, and then I do take telehealth consults, and there's also a wait list. So the biggest thing for me is the reason why I still keep open is I really want to help patients as best I can. I just don't have tons of spots available. So what I'd recommend is if you really want to do a telehealth with me, or if you really want to see me, you can just know that either I can help refer, we can get you to the right people that are in your area, or I can do a telehealth and figure out, does that make sense? Like based on what I'm hearing, would it make sense for you to see me, or can I get you to someone else that can also help you? So I'm really big about collaborative work and trying to get people to where they need to go. It's not like, hey, you need to see me or you'll never get better. It's really trying to figure out and help them navigate it. So the answer is yes-ish. Yes, I'm seeing patients. It's just a little bit more limited than I wish. I want to see everyone all the time, but it is a little bit more limited right now.
And is fecal incontinence connected to hypertonic pelvic floor?
Wow. Okay, so fecal incontinence can be numerous reasons. Typically, fecal incontinence is more about a decrease in tone. So there's not enough tone. There's people who have some tightness, and by virtue of having so much constipation and tightness, outlet dysfunction, they end up having oozing of fecal incontinence simply because they have too much pressure and they're having so much constipation and tightness that it actually oozes out. So there is a form of fecal incontinence that can be from an increased tightness of the pelvic floor. But usually we first look at the tone. Is it too loose or too weak first, or not coordinated? And then we look at, is there a tightness? So yes, that is one component of fecal incontinence, but not the primary thing. Oops,
Okay.
that helps.
And what are your thoughts on and forget how this is called because I'm sorry.
That's okay.
The rollers that a lot of PTs suggest.
Yes.
Um, is that mostly in the beginning of PT, like if you're having a lot of problems with exercises, do they start first with rolling to get your tissues more blood there, I guess, or I'm not even sure how to phrase that. I'm sorry.
Yeah, no, it's okay. Not necessarily. So here's the thing. This is where, again, I want you to really think about if you can take this information and impart it no matter where you go. If it doesn't matter if they're the top expert in the world, if someone gives you something to do and it flares you up and it makes you feel worse, don't do it. Now, can you modify it? Can you do something different? Yes, but and it might be that you can do it in a year from now or 6 months from now. But if something consistently flares you up, don't do it just because someone's telling you to do it. Okay. There are people out there online who say, like, I've developed a Pudendal protocol, and all of my patients get on this roller and they do it 10 minutes a day, and then they do this. I'm telling you, there are patients that tolerate that beautifully and do great with it. Then there are many patients who actually get flared, but keep pushing through and keep pushing through because they were told that this is the Pudendal protocol. And so my answer is, for the most part, anything hard or compressive is usually not, if someone truly has a pudendal nerve irritation or some sort of nerve issue, usually that can be really uncomfortable for them. But I have a subset of patients who love taking a ball and sitting on it and digging in there, and they say, oh my gosh, that gives me so much relief. Then great, then go for it. It's the same for anything. If someone does acupuncture and they say, wow, it really helps me, I love that that's one component of multimodal care. That's awesome for them. But I have many patients that are like, oh my gosh, I tried a year of acupuncture and it never worked. Should I keep trying? I'm like, no, if it's not working or if it's making it worse for you, then don't keep doing it just to do it. So it's the same thing with those rollers and all the exercises. I've seen those crazy things where you can dig deep into the psoas and that's supposed to relieve things. Again, for a lot of people, that's going to be way too much and not the right treatment. So it's not one size fits all, and it's really figuring out, does that help your symptoms getting better? Sometimes, almost like inadvertently, when someone uses a roller, if they put the foam roller kind of thing in between their shoulder blades, or they put it horizontally and they open up, they'll say, I don't know what it is, but I always feel better. That's my clue that they're actually getting an extension around the spine and it's opening up the spinal nerve roots there. It's giving them more space. So it's not the foam roller itself. It's the fact that they're actually getting into a really good position with their spine. So that tells me there might be something else going on spine-wise that we can continue to work on with them. So it can be diagnostic in a funny way. Not, they might not be realizing that. They might thinking they're just stretching things out, but it's actually really indicative that it's actually a really good motion for them to open up the spine.
Great. So I think that's it. I just double checking.
And I really appreciate you all asking questions. I'm happy to be here. I try to go in the group as much as I can and answer questions and just, be the light and try to give you more information so that you feel empowered. Like I said, I've been doing this 25 years, and there's so many times I want to, wrap my arms around someone and say, you got this, there's a way out of this, because I see what they're going through and I can't get to every single person, but I know that sometimes it feels like there's no hope, or it feels like you're stuck. You can't get out of where you are. And there's usually a way to figure that out. Okay, so I do see one other question here. Outer vulvar itching and prickliness alone be caused by entrapment. Yeah, I mean, the vulvar itching and prickliness can be multiple things. They can be hormonal deficiency, estrogenic issues, androgenic issues, meaning like someone's been on birth control for a long time and it's changed where they have an androgen factor that's making them more itchy and burny there. And they actually need to get off of birth control for a little bit and get more estrogen cream there. It could be perimenopausal changes, breastfeeding changes where they get that, where it's actually an estrogenic change at the receptors there, vulvar area. It could be that someone has some form of a BV or some sort of other kind of condition that's more medical condition there. It could be that they have lichen sclerosis. It could be that they have pudendal nerve irritation. So there's a lot of things we consider before we think, oh, there's definitely pudendal nerve entrapment. And also, I don't know if you were here earlier, but we also sometimes we find that the perineal branch of the pudendal nerve gets irritated, and you can work on the bulbo cavernosus muscle. And that seems to help tremendously with patients just working on the muscle there. So any of those things could be, but it's usually, I don't think of entrapment there as the first thing when I hear those symptoms. It could be a dermatologic issue. Sometimes we just see contact dermatitis in that area or something like that, or a sensitivity to a detergent or soaps or things like that as well. So there's lots of things to consider. And that's what I'm constantly doing. It's a catalog of all the differentials of what something could be. And then if it goes beyond my scope, I might say, okay, I want you to see this vulvar dermatologist, or I want you to see this person. I try to connect people with the right specialists.
So
yes.
There's one I missed, but the question kind of confuses me. I'll ask it a little differently. Do you know of any limitations on age for access to pelvic floor therapy. I wasn't
Limitation on
aware of
age.
anything.
Oh, I know, I think I know what they're talking about. So there's this very terrible thing that happened, and we don't understand even why it happened. But okay, many of us had to, if you try to go through insurance, if you're trying to get covered under all insurances, you run into problems where you don't get reimbursed for your care. Okay. So some people do hybrids where they do Medicare and then they do the rest is considered out of network care. So if someone's over the age of 65, they can still go see that provider, but they also they can see anyone that pays cash. There was a strange law that happened, and like I said, we don't know why. But if you're an out-of-network provider and you don't take insurance, you simply don't have a relationship with insurance. If you're age 65 and you have Medicare, you technically cannot see a Medicare beneficiary. It's the strangest rule. A person that is a Medicare beneficiary can go get a massage. They can go to a doctor's office, any kind of physician's office. But to go to a physical therapist or occupational therapist or speech therapist and pay out of pocket without using, you cannot use insurance, and you're not technically even supposed to take any financial anything from them because they're a Medicare beneficiary. So we have this crazy thing that we've been fighting for years to overturn because it makes no sense. And there are some people that do it anyway because they're just like, I'm just going to do it and take my chances. But many people are really nervous because technically it's a law that you're not supposed to. So I think that's maybe what you're referring to, unfortunately. And many pelvic health professionals are having to do out of network to really get reimbursed. Again, not across the board. There are many hospital systems that do pelvic therapy that take all insurances. There are some people that do hybrids or some form of insurance, but there are a lot of pelvic health professionals that are specializing that don't aren't doing that. So that might be what you're referring to, I'm thinking.
Yeah.
And
And
it's super
some
frustrating for us, very frustrating.
very frustrating. I didn't realize that was a thing. That's
It's a thing. It's been, I mean, I've done papers on it. I've been trying to do everything I can to figure out loopholes, and it's just really frustrating. Yeah.
And have you run across patients that have decreased nerve feeling to urinate, however, they are not incontinent?
Meaning they don't have I wonder if it's like they don't have an urge, a sensation, or like while they're urinating, they can't feel it.
I'm not sure. She did
Yeah.
not specify. Um, I'm guessing
Yeah.
not feel it.
You can, okay, so basically with your nerves, you have what's called ventral and dorsal nerve inputs, and you have motor and sensory. So you can absolutely have complete motor function where you have the ability to contract the pelvic floor, relax it, not have any incontinence, but have changes in sensory component. So that absolutely can be the case. And then the
Okay.
question is, why are you having the sensory changes? Is it, again, more hormonal? Is it something else going on? Another disease process, diabetic, and there could be a variety of different reasons why someone has sensation changes.
Okay, let's see.
I see someone is thanking you, Cora, and I have to say, I will thank you again because you are so kind to reach out to do this, and you are such an advocate for everyone in this group. And I was saying, I've been a member of this group. I've been active in this group for years. I was thinking maybe 15 years. I don't even know how long it's been available, but I know I've seen patients over the past at least 13 to 15 years from this group or been involved with this. And we've never, that I remember, we've never had anyone take this kind of advocacy and get professionals to come on and do this. And so I really do applaud you for doing it because I know this is a lot of work for you, a lot of behind the scenes communication. We've communicated a ton to get this to work. And so, yeah, I just know that what you're doing is really appreciated.
Thank you. I really do appreciate that. But I appreciate you coming out here. I know you take your time to come out and do this for everybody. And I know, a lot of the people that I talk to that reach out to me are people that are bedbound or people that are really losing hope, because there's a lot of sad stories on there. Because, it is a support group and a lot of people come on and pour their hearts out and their situations. And it's hard to sometimes find hope. And so having someone come out and give them hope means so much.
Yeah.
And so thank you so much for doing that. I found this incredibly helpful.
Oh,
Uh,
good. That's what I'm hoping. And the reason why I think it's important to have different types of professionals is that you're seeing different scopes. You're going to see a physician who's talking about all the injections and surgeries, But really, a lot of people don't even need injections and surgeries, right? There are people who absolutely would benefit from that. So it's seeing different scopes. So people understand that there's various ways to look at this and go after this instead of thinking it's only one or the other. So yeah, it's really great to have different perspectives on here.
And can you clarify again? I know you said 4 to 6 times for therapy sessions. Someone asked if you've been in severe pain for a
Mhm.
very long time, can you still get relief if you come into PT? So someone who's maybe been at it for, 10 years, let's say, and haven't
Yeah.
found.
It's actually really interesting that it's not necessarily always a function of how long someone has had the problem. For example, if we can identify the problem, okay, so there's some things. For example, I use this a lot. If someone has not a dermatologic issue, if they have a vulvar issue that needs vaginal estrogen, but they think they have pudendal neuralgia, once you get started on using the right appropriate dosing of vaginal estrogen, it can take 2 to 3 months to work. Okay. So, what some people might say is they might do therapy at the same time and do 4 sessions of therapy in 1 month and be like, I'm not better yet. Well, in that case, we don't know yet because we still need to wait another month or two to see if it's working. So, some things naturally will take a little bit longer. If someone has had a problem for 10 years of pelvic pain, sure, they might have a lot of things going on that's even more than just what they initially had. They might have so much tightness, they might have other dysfunctions that, yes, it can take longer than a 4 to 6, 4 to 6 visits potentially. But what I'm saying is even in the 4 to 6 visits, I should see some movement. I'm not saying complete resolution, but wow, I noticed that I go 2 hours a day now without as much pain or discomfort, or I noticed that the exercise you gave me really helps me manage this better. You start to see some things are on the right track. I'm trying to see if there's some change in the way that their pain is behaving, essentially. Then I know we're in the right track. I'm not suggesting after 4 to 6 visits it'll be totally better. But
Right.
even if someone's had it for 10 years, I've had some cases. I had a patient, this is so fascinating to me. Unfortunately, she had a lot of trauma in her life as well. And so we deal with a lot of that too, a lot of traumas, which is really, if you're trauma-informed care, if you're doing it right, you're helping a lot more patients because trauma-informed care is really important. Um, so I had a patient who had significant dyspareunia and vaginismus and pudendal nerve pain. So basically, she was not able to have intercourse at all. I mean, we're talking, I think it was maybe 20 years of not being able to do it, a long time. And I said, well, here's the thing, based on the findings that I see and the plan, we're going to do desensitization strategy. We're going to do a dilator program specifically. We did a variety of things to set her up for success. And I said, in the best case scenario, we're thinking probably 2 to 3 months. You'd be better with this, but it could take longer because she'd been dealing with this for 20 years. There's a lot of overlay of trauma and other things. And she came to me, she goes, I wanted to come to you on exactly 3 months because I wanted to report to you that I don't have any of the problem or the pain anymore. She's like, I cannot believe it. You said 2 to 3 months would be the minimum. And I've been dealing with this for 20 something years. And she's like, I cannot believe at the exact 3 month mark, I can say that I'm a lot better. I'm basically better. So it doesn't, it's amazing how some of these stories, like I'm blown away because I wasn't expecting it to be 2 or 3 months. And yet sometimes, patients surprise you with their effects and how they do. So yeah, it's not distinctly that if they've had it a long time, they'll always have it a long time. But again, the norm is that, yeah, normally it might take a little bit longer given the fact that they've been dealing with something for so long. And
So I
there
know
is
you
sensitization that happens within the brain and spinal cord too.
So I know you mentioned suppositories earlier. Could you clarify for suppositories, when they work for nerve pain, does that mean that there isn't entrapment? Is there a way to know that?
If,
Or,
if any treatment helps even temporarily, like we're talking an hour or two, someone does not have distinct pain or it's a lot lower, again, that's probably indication because most people do not have entrapment. So that's a good sign. Suppositories, if they are some form of muscle relaxer, the typical ones we see, and again, I can't suggest one or another, but the typical ones we see a baclofen, we see diazepam, we see ketamine, we see other variant, like other things mixed together,
Mhm.
like a gabapentin or something will be mixed in there. So there could be compounding. But if it's some form of muscle relaxer that's helping, that means that what it's doing is it's probably relaxing the local muscles in that area. So it's taking pressure off the nerves as well. So that's a good sign that something can be done to neuromodulate so they're no longer having that distinct discomfort or pain. So then we just have to capitalize on it and say, okay, how long do you have to do this for, while we also work on some muscle stuff, while we also work on any kind of other neuromodulation techniques. So it's a good sign for me if they get relief from that. It doesn't mean they have to be on them forever. I try to get people to wean off of them by a certain period of time, but it is a good indication that it is, in fact, one way to change the discomfort they're having.
And do a lot of your patients take medication? Or what percentage of your patients was specifically asked? Do they take,
Yeah.
like, say, gabapentin or something like that?
Okay, so some patients come to me already. Okay, so I have different components. I have some patients that have already come to me that are heavily medicated, that their goal is to try and get off of medications. I
Yes.
have some patients who come that are taking maybe one or two medicines that are really happy and just now looking for an adjunct to add to it. Then we have patients who are on zero medications and are trying to avoid medications. They're trying to see what they can do to not do it. And then I have others that are not on medications, but are open to the idea of facilitating improvements while they, can do maybe a little bit of medications and then get off. So I see every one of those categories. And I mean, I have some patients that are so significant that they have not only pain pumps, but they're on significant amounts of medications. And I've had patients that have been on the equivalent of um, cancer types of pain medications just because that's how they're having to cope. And we're trying to figure out what we can do to see if there's anything else that can help that so they can get off of those things. So there's so many different categories of people doing that. My goal is to see if we can do things conservatively as possible where they don't need medications. But I often find that for some cases, it just makes sense to suggest, hey, why don't we get you the specialist to see if this would make sense in your case?
Yeah.
I feel like this might make sense in your case. But again, I'll go back to vaginal estrogen. To me, that's like a certain age and a certain type of diagnosis. It would just make sense for someone to try it. If they're having vulvar and vaginal discomfort, it typically just makes sense. So then I start to refer quicker for that than waiting a year or two. It just sometimes it makes more sense to do that. For other kinds of medications, we might want to wait a little while to see if they get better without the use of them.
Let's see.
So yeah, so I guess we'll start wrapping it up. And if there's any final questions, I'll be taking them. But otherwise, I really, really appreciate y'all tuning in. Again, I'm coming from a certain angle of this many years of treating patients specifically. Most of my practice is pudendal and pelvic pain patients, or complex postpartum or complex something where there's been some sort of issue that happens. So I do tend to see cases that are more on the difficult side and try to do my best to either get them to the right specialists to help them as best I can, and do a lot of case management as well, as best I can as well. So thank you for your time.
Thank you so much for joining us. And this presentation was absolutely amazing. And thank you for doing the anatomy portion too. I know a lot of those questions get asked in the group specifically, so that was absolutely wonderful.
Yeah, I was
So
happy to do that. I can talk about anatomy all day long. I really enjoy it. And I do find that there's a lot of questions where people get confused about anatomy and nerves. And just remember, there are a lot of nerves in that area. So we talk about pudendal a lot, but there's a lot more to figure out. Is it coming from spine? Is it coming from other nerves? When does it matter if it's nerve? I want to just make one final point to all this. Just remember, if someone has knee pain, they have severe knee pain, we don't immediately say, oh, it must be this nerve and we've got to treat this nerve. We've got to do this nerve block, right? We would think, okay, is the knee pain a meniscal issue? Is it something to do with the ACL? Is it that they have arthritis? We would look at a lot of differentials, right? So similar thing, when you're having pain there, it's not necessarily just let's focus on the pudendal nerve. We're trying to think of everything that could be contributing. And so if we look at it from that lens, I think it'll help as opposed to chasing the pudendal nerve all the time. It's really figuring out the whole person and what's going on with them and their individual anatomy there is what I would say.
okay.
All
Well,
right.
everybody, thank you for joining us and have a good night.